Good afternoon and welcome once again to our weekly COVID-19 public health update and media briefing with Montgomery County Executive Marc Elrich. I'm Lorna Vigili, Hispanic Public Information Officer, and joining us today is Dr. Earl Stoddard, who is the Assistant Chief Administrative Officer for Montgomery County Government, as well as Sean O'Donnell, Program Administrator, Public Health Emergency Preparedness and Response for the Department of Health and Human Services. Joining us today also is Maryland Delegate Ariana Kelly. Welcome, Ms. Kelly. Good afternoon to you.
Yeah.
And with that, let's get started, Mr. County Executive, with your opening remarks.
Okay, so I want to welcome everybody again this week and thank you for joining us. I've had a busy morning already. We had a meeting with the Secretary of HUD, Secretary Fudge this morning on a roundtable discussion on housing supply and affordability over in Suitland, Maryland. And it was convened by COG, and there were a number of regional leaders there. Also, Craig Rice joined me from the council. And it underscored the issue that affordability is actually a region-wide issue. And we had a really good discussion. And she indicated that the federal government is ready to make investments and that it recognizes the importance of those investments if we're going to go forward and build affordable housing. And she had some pretty progressive ideas in recognition that we need multiple approaches to solve this problem. Our discussion touched on a whole range of issues from homelessness to ownership, and I really do look forward to working with our federal partners. I thought the discussion was really productive, and she entertained comments from many of the leaders around the region. On a different topic, I want to acknowledge that all of us have probably been watching information about the invasion of the Ukraine with dismay and apprehension. We wanted locally to be able to take a stand to demonstrate our solidarity with the people of Ukraine, which is why we have removed all products produced in Russia from the county's alcohol beverage services stores until further notice. And I also want to note that a note of appreciation to the president of the employees union, McGeo, Gino Wren, who made this suggestion pretty quickly and asked us to consider taking the products off the shelf. I've asked our team at HHS also to look into ways we can prepare and help for any Ukrainian refugees that might wind up seeking refuge here in our county. On the COVID update, I want to first hope that my Congressman, Jamie Raskin, has a speedy recovery from his COVID case. If any comfort, I've been through this, and I had it for 13 days, but mine stayed relatively mild. And I hope that he has a similar experience, if not better. I want to note that this week marks the 2-year anniversary of the COVID pandemic. I actually remember I was at, I think it was People's Baptist Church, and we were in a forum, and I got this text, and I wound up announcing to the whole group that we had just had our first cases of COVID. On March 5th, the first 3 cases were noted in Maryland, and they were identified as coming from Montgomery County. It's hard to believe we've endured 2 years of this life-changing pandemic. And I want to thank all the many individuals and organizations who worked extremely hard to provide resources and keep Montgomery County residents safe as we fought through the pandemic. Due to the incredible work of our government employees, the volunteers, our residents, and our partners, Montgomery County remains one of the most highly vaccinated places in the country with one of the lowest rates of COVID among large jurisdictions. Most importantly, we're saving lives in our county, as our county's death rate from COVID-19 is nearly a third lower than the national average. We'll continue to use what we've learned over the past 2 years in our ongoing response, monitoring the situation daily and doing everything we can to reduce the risk, including encouraging vaccinations and particularly now getting boosted. The good news is that unlike when this first hit, we now have a good sense of how to stifle the spread. There's a lot of obviously unknown factors surrounding COVID when we first were experiencing it. But what became really clear is this virus is a is transmitted person to person. And to the extent that one limits person-to-person contacts, one is able to limit the spread of the virus. Fortunately, that's a pretty easy equation. Sometimes it requires doing some pretty difficult things. But knowing what we need to do and what works, I think is going to help us moving forward. And, one only has to look at the data and to see what happened when places loosened up before we did versus when we made the decisions to loosen up. And invariably, the county wound up with fewer cases and fewer deaths. So we had a good real world test case to see how best to handle COVID. And I think we understand this, pretty well at this point. Based on the CDC's new community level indicators, our community level is now low. As you can see from the chart, we're experiencing dramatic decreases in our cases and our positivity rates from just a month ago. And this chart shows, that we're now low. We've fewer than 200 cases per 100,000 residents in the past 7 days, and fewer than 10 new COVID-19 admissions per 100,000 in the past 7 days. So things are moving in the right direction now. For our county and all over the region, mask mandates are being lifted in public places. For now, businesses can decide whether to require employees or patrons to wear masks. That is always their decision when the county doesn't have mandates on. And even though for many the masks are coming off, we can't lose sight of why they're coming off. They're coming off because we have a lot of people vaccinated. We now have more people, unfortunately, who have immunity from having gotten sick. And now what we need to do is to get everybody who remains, who hasn't had the booster shot, we need to get them to get boosted. More than 85% of the eligible population have gotten their shots, and 52% of our fully vaccinated population has been boosted. Those without boosters are more vulnerable. They remain more vulnerable. The data shows there's a difference between being vaccinated and being boosted. And being boosted provides a much higher level of protection from not just COVID period, but from the severe effects of COVID. And if you're over 65, the risk of severe illness continues to be greater, as does the risk of death, and boosters are even more important to people in that population. So we're going to continue to urge everyone to get their booster shots. We know it saved lives during the Omicron surge, and it's going to surge, and we know it's going to continue to save lives. We'll continue to have the vaccines available, and we will continue to be administering them. Right now, masks are still required in schools, and the School Board of Education will vote on the mask mandate their upcoming meeting on March 8th. The state lifted the mask mandate for schools, leaving the decisions on masks in schools up to individual school districts. This week, we're going to start a month-long period of COVID remembrance throughout March. We're going to take time to remember friends, neighbors, coworkers, and loved ones in Montgomery County who died from COVID-19, and reflect on the challenges we've faced as a community over these last 2 years. This Memorial Week, Montgomery County is going to remember those who we lost over the last 2 years. There's information about where the ceremony will be. It'll be in Miriam Fryer Plaza in Wheaton, and we're going to hold a candlelight vigil there on Thursday, March 3rd at 7 p.m. Public Health and Healthcare Week is going to be March 6th to 12th. Housing Week is going to be March 13th to 19th, and Essential Worker Week is going to be March 20th to 26th. And Food Security Week will end the month from March 27th to April 2nd. Our fight against this deadly virus continues, but as we approach the second anniversary of our first case, I'm asking the county residents of this county take time to remember those we lost and acknowledge the countless residents and organizations who work tirelessly to help save lives. I always think about the earliest days of this, when we asked people to go do their jobs, make sure they were taking care of people and addressing the needs of the community, when we didn't have the equipment, personal protective equipment, to really provide the safety that we know that we actually needed. And we managed to get there like everybody else in the country did. But in those early days, people made enormous sacrifices probably nobody made more sacrifices than the folks who worked in the healthcare industry, because they were up close and personal with the sickest people in the system, often in hospitals that were overloaded, and their sacrifices and the challenges they faced, I really think deserve our acknowledgement and respect. It's really a shame that at times these folks became targets of the anti-vaxxer campaigns, but we would not be where we were it not for the sacrifice and the willingness to do their jobs during very, very difficult times. We wouldn't be here today without the collective efforts, and we're going to take this month to simply say thank you. Each week during the remembrance, we're going to focus on these different themes I outlined. And so you can join tomorrow night at the Candlelight Vigil. It's going to be at 7 o'clock at, as I said, Marion Fryer Plaza in Wheaton. It's right by the Metro there off of Georgia Avenue. We can stand together as one county and remember the people that we lost in this fight. For the rest of the week, I'm asking county residents to join our tribute to those we lost and share your stories and pictures on social media. Please use the hashtag MoCo Remembers. We've lost nearly 2,000 people, and each of them has a story. This is our time to honor them and their legacy, and I hope you'll join me, members of the council and religious leaders, for this special tribute. I do agree with President Biden's ending words from his State of the Union speech. We are stronger now than we were a year ago, and will be even stronger a year from today. I think that is absolutely true. I think we're in a far better place between the scientific advances, the improvement in our state of knowledge, and the accessibility of the kind of equipment and tools we need. We are in a better place, and we will wind up in a better place. And we're stronger because the people in this county did what they had to do to protect ourselves and our family. And I can't thank you enough for that. As this was rolling forth around the country, you heard from people who tried to give the right advice. And in a lot of places, you saw people ignore that advice to their peril. That didn't happen here. And I really am appreciative of our residents for their willingness to take the precautions we needed to keep this county as safe as possible. Earlier this week, I issued an executive order to rename the Silver Spring Library after Tuskegee Airman Brigadier General Charles E. McGee. We ended the month of February in Black History Month on Monday, and I was joined by Councilmember Will Jawanda for the signing of an executive order to rename the Silver Spring Library after Tuskegee Airman Brigadier General Charles McGee. It was a very special moment because we were joined by his family, members of the Tuskegee Airmen, the Montgomery County Commission on Veterans Affairs, and his fraternity brothers from Alpha Phi Alpha Fraternity Incorporated. There's no better way that I could imagine to conclude Black History Month than by memorializing Montgomery County resident who is an extraordinary American hero and a trailblazing African American, a man who lived an extraordinary life. He passed away earlier this year at the age of 102. He served as a fighter pilot and a member of the 332nd Fighter Squadron, famously known as the Tuskegee Airmen, an all-Black unit in World War II, followed by combat missions in Korea and in the Vietnam Wars. He fought against racism and equality for his entire career and paved the way for African Americans as service members. We're renaming the building for General McGee because of his example and the opportunities he provided to the generations who followed in his footsteps. And he was a big believer in the value of learning, and the library is certainly, as the major repository of knowledge for all of us, is an appropriate place to name him on his behalf. I want to thank Councilmember Jawanda for championing this effort. I look forward to the dedication ceremony. We actually put his name on the building. And I think this is the time for all of us to remember that how segregated the Army was, how they did not want Black soldiers to fight alongside of white soldiers, how they did not want to put guns in the hands of Black soldiers. And when these people came home from World War II and Korea and Vietnam, after serving their country, they continued to face racism, discrimination, and denial of access to all the things that many of us have taken for granted. So it's something to think about somebody who put themselves on the line and put their life at risk in 3 different wars, and knowing that he was coming home to a country that would not treat him as an equal. Hopefully we will get to the point that we move past those dark days and that never happens again. This month is Women's History Month, and as we begin the month of March, we're celebrating Women's History Month and honoring the women in our county and our nation for their invaluable contributions and selfless service to others. It's also a moment to remember the importance of protecting a women's reproductive rights. Opponents to women's reproductive rights are succeeding in states such as Texas and Mississippi, and the Supreme Court could issue a ruling this year overturning Roe versus Wade, which gives a woman the right to a safe, legal abortion. Why is this important for us here in Montgomery County? Delegate Ariana Kelly, who represents parts of our county in District 16, says even in Maryland, considered a safe state for abortion access, we do not have sufficient abortion access. And I've talked to a clinic provider before. They work sometimes under fear and harassment. We've seen examples around the country of both killings and firebombings of clinics, all because they're trying to provide a woman with safe access to something that she has a right to. This idea that a small group of men continue to insist on their ability to tell a woman what to do with her body is shameful. And hopefully at some point we'll move past that too. More than 2/3 of Maryland counties do not have an abortion provider, forcing many women to other parts of the state or even out of state for safe abortion care. Delegate Kelly is sponsoring the Abortion Care Access Package of bills to protect abortion access and ensure equal abortion access regardless of income. Delegate Kelly is here with us today as we start the beginning of Women's History Month, and we'll be talking about how we can protect women's reproductive rights. So first I'll turn it over to Delegate Kelly, who has to leave at 1:15, and then we'll resume the rest of the COVID part of the briefing. Thank you.
Thank you so much to the county executive for having me here to talk to you about this today and for his stalwart support of abortion access in Maryland. I'm going to speak briefly because I do have committee hearings starting, but I just wanted to make sure we set the context. This is Women's History Month. You probably remember, if you were around like I was back in 1992, we had a statewide referendum codifying the principles of Roe versus Wade in Maryland law. The interesting thing is that since 1992, we have done nothing since. We haven't moved forward with healthcare policy around abortion at all. There's been no legislation at the state level, but the world has significantly changed and the way that we deliver healthcare has really changed. So we have the Abortion Care Access Package of bills this year in Maryland. Finally, after 30 years, we're going to be moving forward. So I have House Bill 937 and 952. They're cross-filed in the Senate by Finance Committee Chairman Dolores Kelly. There's also House Bill 1171, which is sponsored by Speaker Adrian Jones. And these three pieces of legislation work together to address the challenge that the county executive just raised. 2 out of 3 counties in Maryland do not have abortion providers. Our number of abortion providers have been dropping since that statewide referendum in 1992. They've dropped by 15%. While the population has gone up by more than 25%. So already you have a huge imbalance there. In addition, there are increasing barriers to clinical training for abortion providers, both in the state of Maryland and also, very importantly, for those practitioners who are trained out of state. If you are trained as a physician in Texas or Mississippi, you are not getting access to abortion training. So if you move to Maryland and you want to work here, you haven't had the clinical training you need. So that's an issue that needs to be addressed. One of the things that we know is that after the Texas abortion ban or near abortion ban went into place, the neighboring states started seeing increases in their wait times for appointments from 19 to 22 days. So people in Oklahoma and Louisiana now have to wait almost an extra month to receive abortion care because of the pressure from Texas. And we're expecting the same thing to happen here in Maryland. When the Dobbs case comes down, which is probably going to be June, maybe May or April, from the Supreme Court, if they do what is predicted and severely limit or perhaps overturn Roe versus Wade, 26 states could ban or severely restrict abortion. That's going to have a tremendous impact on our ability to provide access to care here in the state of Maryland. So the abortion care access bills do 4 really important things, and the county executive touched on them a bit. The first thing that they do is increase the number of qualified clinicians who can provide abortion care. We have this restriction in our law from back in 1992 that's called physician-only language. It says you have to be a physician to provide abortion care. However, healthcare's changed a lot in the last 30 years, and nurse practitioners and nurse midwives and physician's assistants are all able to provide abortion care. There's consensus within the medical community that that's appropriate care for them to be providing. We have 14 other states already that allow these advanced practice clinicians to provide this care. We want Maryland to join that list of states. We're also hopefully going to be making an investment in clinical training so that clinicians who are trained in states that are not supportive of abortion access will be able to get the training they need to provide care here in Maryland. In terms of financial barriers to care, the legislation does two really important things. Number one is for those folks who have private insurance. It requires that private insurance cover abortion care with no cost sharing. That means no deductibles. Deductibles are one of those things that can delay care and that can make care much more costly, difficult, and complicated. So we definitely want to remove that financial barrier. But the other thing that is incredibly important is that we're going to equalize Medicaid. Medicaid in Maryland has covered abortion care since 1979, but for people who are in Medicaid, that is subject to budget debate every year. And that's just wrong. We shouldn't have a world where some people's rights are in statute and permanent and other people's are subject to debate every year. So we're going to make sure that Maryland Medicaid is permanently covering abortion care, just like private insurance, with no cost sharing. So those are major provisions of the Abortion Care Access Bill, and they work in tandem with the Speaker's bill, which is the constitutional amendment that would be another referendum similar to what we did in 1992, but this would elevate those protections to constitutionally protected, making it much more difficult for those rights to be rolled back in the state of Maryland. So that's the approach we're taking. We have already had very good hearings on the bills, and we are expecting a committee vote on Friday in the House Health and Government Operations Committee on this package of legislation. So I think that was my 3 minutes, but I really thank the county executive and the team for their the opportunity to share this information with you today, and in acknowledgement of Women's History Month.
Thank you, Delegate Kelly. Who will be presenting now? You, Mr. O'Donnell, or Dr. Stoddard?
Well, I think in the interest of time, I think one of the things we have on the table is if there's any questions for the Delegate Kelly, we could entertain those now because I know her schedule is will require her to leave soon.
I do have a couple of reporters that have questions. Are they directed to Delegate Kelly, Kate Ryan, Rebecca Tan?
Hi. Yeah, I'll ask my question if that's okay. This is for the county exec. You mentioned masking. You know, the county
no only for Delegate Kelly right now.
Sorry.
We'll come back to you.
Yeah, she has a hard time in a couple of minutes.
Question for Delegate Kelly from Kate Ryan at WTOP. Delegate, the legislation that you're talking about, what is the situation with medical versus surgical procedures? Is there any distinction in these laws, either on what rights may be rolled back or what gets protected?
Thank you for that question, Kate. That's a very good one. So right now, as I mentioned, the law hasn't been updated since 1992, which means that our law was created before medical abortion was common. And now more than 1 in 3 abortions in Maryland are medical, as opposed to what we'd call procedural or surgical abortions. The law that we're interested in passing is going to keep the standard the same in terms of who's able to provide the care, which would actually be a change from what's happening on the ground. There's an Attorney General's opinion from 2020, 2 years ago, that looked at our 1992 law and said, advanced practice clinicians, exactly those clinicians I was talking about, nurse practitioners, nurse midwives, physician assistants, can already provide medication abortion. That's the Attorney General's opinion, but what we want to do is make sure that we're codifying that in the statute so that they can continue to provide that care and feel as though they have the protection of the law. At the same time, it would also allow them, when appropriate, when they have appropriate training and competency, to provide procedural abortion as well, which can be very important, particularly in an area like the Eastern Shore. We heard in the hearing testimony about a provider on the Eastern Shore who can currently provide medication abortion, but her patient needed a surgical abortion because of some indications in her health history, and she wasn't able to access that care for multiple weeks because she was on the Eastern Shore and she would need to get to Baltimore for that care.
Thank you.
Thank you.
All right, can we move forward now with your presentation, Mr. O'Donnell?
I'd be happy to. Okay, so some of the most notable updates over the past week have been with regards to changes in guidance from the CDC and how that will affect and impact what we're doing here in the county. The biggest thing is the CDC is moving on from their guidance based on transmission levels to guidance based on community levels. It retains using one of the metrics that we have been using, which is the overall transmission level per 100,000, but then it adds in 2 additional criteria that we have looked at, but it's now shifting their focus to those criteria, which is criteria related to hospitalization. So they're shifting from looking at all cases of COVID to looking at those cases that are more medically significant. And some of this has to do with the increased levels of population immunity that occur across the United States due to vaccinations, boosters, and the large number of infections that occurred during Omicron. So within the CDC's guidance now that they provide across the nation, they are looking at the new COVID-19 admissions to hospitals per 100,000 over a 7-day total, as well as the percent of staffed inpatient beds over that 7-day total that are COVID patients. We have reported on the second one of these throughout this. So these are not necessarily new things that we look at. It's just a shift in how the CDC is providing their guidance. When we look in Montgomery County, as of data over the last day or two, we are seeing that we're now at the 60 cases per 100,000. So we're definitely in that first category of fewer than 200. And so then when we look at the metrics here in the upper portion, we have averaged over 7 days, there's been a total of 2 new admissions per 100,000, very limited new admissions to our hospitals. So that's under the threshold of 10. And when we look at the percentage of our inpatient beds occupied by COVID-19 patients, that's down to 4.4% of all of our beds. So again, we're squarely in the low level under the new CDC guidelines. So what does that mean as far as their guidance to us? It means that they're still recommending that we stay up to date, that all individuals stay up to date with their COVID-19 vaccinations, and that everyone should get tested if they have symptoms. Additionally, people with symptoms, a positive test or an exposure to someone should continue to wear a mask. So those things have not changed. The quarantine isolation guidance has not changed either. When we look at the community levels across the United States, currently it's a little bit less than a third is in the low category, a little bit less than a third is in the high category, and the remainder are in the medium category. And much of Maryland is under this low criteria. Going in a little additional in depth of what the CDC is recommending with that community level, they again are recommending that everyone continues to follow their guidance for isolation and quarantine. Currently, the county's guidance is identical to the state and CDC guidance for that. And they're also recommending that immunocompromised or other high-risk individuals for severe disease are aware of their options for rapid testing if needed, or other types of testing. In the county, we've certainly made that a priority to make rapid tests or PCR testing very accessible to the population. They're also recommending that immunocompromised and high-risk individuals talk to their healthcare providers about the current range of treatments that are available. Oral antivirals are relatively new to the response, but there is a pledge to produce more of them and make them more available, as are there a monoclonal antibody treatment that is given pre-exposure to those who are immunocompromised, and that's the Evusheld treatment. There's lots more information through our website on how to access that. And I just want to, again, accentuate, there is sometimes confusion when we talk about fully vaccinated versus up to date. This guidance is recommending people are up to date, which means not only do they have their primary series of vaccines, but also boosters when they're eligible. If we were to at some point move back to a higher community level, that's when masking, additional masking guidance would be potentially given. It's when additional testing, such as screening testing that has been done in the past, might be reinstated, and additional guidance for those who are at high risk, including entry into facilities that are high risk, which is what we've done with our assisted living and nursing homes, what we've done with other types of settings as well. So this is just a reminder that these tools are still available. If that community level changes, we would look at those again as tools that we might need to implement. We want to remind all of our partners that although the CDC is looking at those a few key metrics within Montgomery County, we continue to use quite a large amount of data to help inform our policies and our guidance to our leadership and to the public. We continue to look at multiple different types of tests between lab confirmed PCR, clinically provided rapid antigen or the self rapid antigen, as well as our hospital information. We continue to monitor outbreaks and that occur in congregate settings and other types of unusual cases that are reported to us. And we still do syndromic surveillance of absenteeism. We look at emergency department data every day, and we look for trends and changes. And we're working with our partners in the region, looking at wastewater testing and how we can make use of that going forward as additional sentinel surveillance. Again, we continue to look at information shared by our state and federal partners as far as vaccine efficacy against different variants, what those variants are and what their prevalence are throughout our community, as well as just overall case rates in different countries and within this country. The CDC shared this framework, which gives helps give a graphical interpretation of how we take those metrics, how we inform the community on the necessity of getting vaccinations, including additional doses, how we use that data to make public health recommendations on non-pharmaceutical prevention measures, and how we make other local decisions and when to gather additional data and when to provide additional information to the public and make decisions through leadership. Moving on to some of the most recent data, as I mentioned a little bit earlier, we're at 4.4% of our hospital beds with COVID patients. That's 62 hospitalized patients as of a few days ago, or as of 2 days ago. And both acute care and ICU bed usage has declined significantly since the height of Omicron. We continue to look at the death data, especially over the most recent wave. And it helps us understand the protective effects of the vaccines in Montgomery County in collaboration with the other protocols that we've had in place. As you can see, that just being fully vaccinated with your primary doses has offered a fairly significant protective effect versus being unvaccinated during Omicron, but there were still a large number of cases of primary dose individuals who were hospitalized. We don't have data at the moment of the booster levels of those individuals. We just have the fully vaccinated status versus unvaccinated. But when we look at the death rates, we do have information there on whether they were boosted or not. And you can see it's an even more profound protective effect against death for those individuals who were fully up to date on their vaccinations. And so that is why we so strongly encourage getting the booster shot. There was a very helpful question the other day by Ms. Tan about the demographic information related to the Omicron spike in Montgomery County. And so we're sharing this with you today. This data is all available through our dashboard. If you click on the additional data button, you can find this data for the entirety of the COVID response. Looking at the case rates by age group, we're seeing here that our 18 to 34-year-olds were the most impacted, or had the highest case rates. Our 5 to 17-year-olds had the second highest case rates, and so on, with our 65 plus having the lowest case rates during Omicron. When you look at that data by race and ethnicity, you see there is a disparity between our Hispanic and non-Hispanic Black populations versus our non-Hispanic white and our non-Hispanic Asian populations in case rates. And again, we've noted before that there is some disparity in our booster rates by race and ethnicity, and it's possible that could be contributing to some degree on some of these. There's likely multiple different factors that are part of this, including underlying conditions. But again, we're sharing the data that is available on what we see in Montgomery County related to Omicron. We've also looked at what percentage of our overall cases and deaths were made up by our populations. And you can see that the prevalence of cases amongst each of the different race and ethnicities can be sometimes quite different from the prevalence of deaths during the Omicron period. And what's notable is within our county, we have very different demographics based on the age ranges of our county residents. And so that goes to some degree to explaining some of those differences. Going to our vaccination totals, again, just a slight update. Now that 12 and up are eligible for boosters, we are also looking at that data, and we'll be updating our pulse report going forward with that. 55% of our, or rounding up to 56% of our fully vaccinated 12 and up population have received a booster. And we're certainly looking to increase those totals going forward. And then finally, just on the distribution of rapid tests, we continue to distribute through our libraries. The big difference this week is that our libraries are now distributing the test kits en masse during all of their open hours, not just during the set hours that we had previously been using. We greatly appreciate everything that our library partners have been doing over the last few weeks and throughout COVID as part of our county's COVID response. But this has truly been a game-changing effort on their part to ensure that testing is widely accessible to our population. So we just want to thank them as well. Those are the updates I have today from Public Health. I'd like to turn it over to Dr. Stoddard for any additional comments he would like to make.
Yeah, I'll just keep mine very brief, hopefully under 2 minutes. So we are focused on starting to, look at the next phase of the COVID-19 response and recovery, rekindling some of our recovery-focused efforts that we began back in 2020, revisited in 2021. We'll be revisiting those again in 2022 to review, obviously the recovery effort has evolved as the response and as COVID in our lives have. And so we'll be looking again at some of the findings we had over the last couple of years, check off the boxes that we have made advances in, and look at the additional boxes around how we can focus on moving forward. The first phase of that will actually focus on how we can get ourselves ready to respond to a future surge. We believe a big part of giving people confidence about being able to move forward in this recovery is having a credible process for having a future response to any sort of surge that we could see from a future variant, whether it's 6 weeks from now or 6 months from now. And so a big part of that effort is to Mr. O'Donnell, Dr. Braders, and I, and members from the team have been working on identifying what kinds of PPE and testing and capabilities we need to maintain, where we need to develop or maintain contracts to make sure we have surge capacity, whether it's for testing, vaccination, contact tracing, or anything in between that we might need to respond to. We expect to be, making progress over that and be ready, and have a system that's in place and ready to operate over the next few months. And a big part of that is actually getting staff ready to getting staff recovered and rehabilitated. Right now, we often say, after a big response, you have to get people the rest and recovery time that they need as we get them and get new hires in, things like that, while we're waiting for the next potential phase of COVID-19 should it arise. The next big thing of our recovery is to focus on addressing some of the issues that have been exacerbated, revealed, or otherwise increased by COVID-19. Those include obviously focuses on mental health issues. They have also, included strains on our technology services across government as we've transitioned to more remote activities. And so obviously we need to go back and take a look at the lessons that we've learned, make improvements in areas, invest in resources to address some of those long-term impacts. This is not just a county government issue. This is a issue that we'll be addressing with our partners, including things like Montgomery County Public Schools, helping them address learning loss through summer programming and summer education, things of that nature. And so obviously we're transitioning some of our response activities to focus more on COVID-19 recovery, even while we credibly make sure that our system is prepared to respond to a future surge. That's all I wanted to speak about today. I think we'll be able to take some questions.
Thank you, gentlemen. Let's open it up for the Q&A portion of this presentation. Rebecca Tan, now the Washington Post. Go ahead. Good afternoon, Rebecca.
Good afternoon. Thank you. My question is for County Executive Marc Elrich. So the mask mandate in the county has been lifted. You mentioned businesses earlier.
Yep.
What is your advice to small businesses trying to figure out what to do at this point in time if they've followed the county sort of guidance all this time and now they don't really have a mandate to go by? What is your advice for what they should be doing right now?
Look, this is really a hard thing to talk about like this. I think if I was a business, I'd consider how many people I had in the business, how crowded it was on a typical day. And I think I'd, decide whether it was reasonable to take the extra precaution or not. I mean, personally, if I go out to a grocery store and a bunch of places I get to, I'm likely to continue to wear masks. There are some places I go where the population density is so light that I don't worry so much about it because I'm not crowded up against people. So I'd hope that folks would take that into consideration. And the other thing is to follow our guidance as we continue to track COVID. I mean, this is only possible because of where the numbers have gone to in Montgomery County. They're trending down. And between the number of people who are vaccinated and the number of people who've gotten sick, there's, we certainly have significantly reduced the possibility of spread. Should those things begin to change, should we get a variant that becomes more infectious, then we're going to have to address our plans and advice accordingly. But I think everybody generally feels that given the current situation, it is not a great risk to be in places where people aren't masked. It doesn't mean there's no risk.
Right. And a quick follow-up question for Dr. Stoddard. Is the county providing any, active guidance or help to small businesses trying to make that decision?
Yeah, we've maintained we have our COVID-19 Q&A page. So any business that is trying to develop a strategy or wants guidance, there's a portal that they can continue to submit to on our website. We still meet. We didn't meet this week. This first week we haven't met in a while just because we didn't have any questions coming in from businesses, but we typically meet every week and we address and provide guidance to businesses on a regular basis. So they can certainly reach out to us. We have a portal that we've used to review plans, but they just want to, ask us questions through that portal. They're absolutely welcome to. So we do provide them very specific business-wide business guidance for when people seek it.
Thank you, Bill.
Thank you, Rebecca. Kate Ryan, WTOP, do you have more questions?
I sure do. Thank you. I did want to follow up on what Rebecca's asking, because I'm seeing in DC, a small business in particular saying that since the mask mandate was lifted there, they're getting hammered by people who are upset with them for asking people to continue to wear masks indoors, but also providing curb service. So they say, look, we're trying to be flexible. We're just asking you to do this for us while you're in our store. Are you getting similar concerns from small businesses in Montgomery County? And one more thing. Oh, and ride-on buses, what's the situation with continuing to wear masks on ride-on buses? Because my understanding is when Montgomery County schools are expected to lift those mask mandates, that those will also apply. In other words, they'll be lifted on the buses as well. So what's the situation with bus rides, and mask mandate? Does the federal transportation thing still stand? And again, are you hearing from small businesses who are concerned? Then I have one more follow-up question.
I personally haven't heard from a small business that was concerned. I mean, it's always been an issue about how customers do or don't respond to the masking, but I certainly respect a small business's right. If they feel they want to make sure they're protecting their employees and they're operating safely, they should have the right to do that. I don't believe putting on a mask to go inside a store is any kind of serious imposition on anybody.
And then what about the ride-on buses, for example? What's the situation there?
So we follow the TSA, which the TSA face mask requirement, I believe, extends through March 18th at present. I don't believe that there has been any announcement as to whether it will be extended or not, but obviously until March 18th, we'll continue to follow the federal TSA public transportation requirements.
Gotcha. And Mr. Elrich, I know that yesterday in Annapolis, there was a hearing on making it harder to fire, that the bill would make it harder to fire health officers in the counties across Maryland. And former health officer Travis Gales was among those who testified. We have been told twice by the county council president that the second candidate who got all the way up to being offered the job for health officer said no thank you because of concerns over how health officers have been treated by the public. Two questions there. What do you do to help avoid that in future? And how is it that the health officer gets that far in the process before saying, oh, I have a concern?
I think when it becomes real and not hypothetical, there's probably a moment of saying, what am I getting into? I can't testify to what people thought or what their process was, but I think that, seeing how health officers are treated around the country and, having Dr. Gale's experience here, which was made kind of fully public, I think people may have trepidation about doing this job. I mean, somebody said there are, is it hundreds of vacancies around the country in terms of empty health officer positions? I do think they should be absolutely protected against being fired. I mean, being fired means being fired by a political person in this case. Having political people firing health officers because the health advice doesn't match what somebody political wants, unless that person's off the reservation and suggesting people drink Clorox in order to kill the virus, I think the health officers should be better protected.
I would also say, Kate, and without going too far into the interview process, we do, interviews in Montgomery County are very much a conversation between a candidate and the county. And we do ask questions about, what their perception, how they would respond to people being abusive. And I think that makes it, I think people really start to think about it in the questioning process. I was told some pretty sage advice by someone a long time ago: never turn down a job you haven't been offered. And so I think people go through the process and then evaluate based on the interaction that they have and thinking more deeply about the position and the challenges that they'll be facing in before they make certain decisions. And then frankly, most people don't discuss it with their families or significant others until they're offered a position. And so I think it often comes down to, people thinking not just about the pressure that they may be put under, but if they have kids or spouses or significant others, it's I may be willing to do this, but do I want to put my significant others through this process as well? And so, it's become highly political in our country. Public health as a premise, and it's going to have impacts for the long term. It's we expect COVID-19 to go away, but there's going to be future pressures on vaccine mandates in schools for things that have nothing to do with COVID as a result of some of the vitriol and political positions that have been taken. So I think it's we're not. This is, I think someone who's going to be here for the long term has got to really seriously think about it. And I think that they have in some cases. We wish the candidates had committed, but obviously, if they had some trepidation, we obviously don't want them to commit and then have to back out when they face those pressures.
Right. And I don't mean to sound like I'm blaming them for going that far along, but it's a question. Has this changed the way you search for candidates? Is the pool that small? And do you have to shift your strategy to find someone who might want to take on this job?
I think that, the most important thing we're trying to do is bring in a health officer that has the wide range of skills and background that we need here. I wouldn't modify it. I mean, we need to find somebody, and there somewhere out there is somebody who's willing to do this, and we need to make sure they understand, what's happened, because I think they kind of intuitively do. But the health officer's job is a lot more than COVID. And in fact, we've been talking about the need to rethink our health system in conjunction with the hospitals and our nonprofit providers because of all the stuff we learned about COVID, pre-existing conditions in the community, and realizing that we need a more robust community care process so that we minimize the amount of pre-existing conditions that people deal with. So I think we've got to focus on what we need and keep interviewing people until we find somebody who's comfortable here. I will say that, here is better than a lot of other places, because here the health officer had the full uncompromised support of the entire political leadership of this county. And so while they may have been buffered by, some not very nice people out there, the fact is that at least, as far as I can tell, they were never undercut by the people that they work with in the county. And I think that's important. Other health officers can't say that.
Got you. Is there any kind of clock running on this? Do you have to fill this time or this position by a particular time, or how long Dr. Bridgers can continue to fill the acting role?
I don't believe there's a clock. I mean, typically it's about a year clock but obviously we're not close to that yet. Obviously there is, I think you mentioned Dr. Bridgers. I think you're remiss if you're not mentioning the fact that he's done an incredibly good job as the acting health officer. And, it's been a pleasure to help work with him and support him. And so, I don't think we've felt I think the county executive was getting this, that we haven't felt any pressure to settle for someone who we weren't going to be comfortable with for the long haul. And I think that's the key thing.
Right.
It might, the pressures of COVID being what they are is one thing, but accepting someone who is not going to be great on maternal child health or on, sexually transmitted diseases or whatever the other public health issue of the future is, would just not be doing a good service to the county.
Oh, right. I'm just trying to figure out if there's a statutory thing that.
Typically, I think it's for appointed positions, it's typically a year, I believe, and I could find, I'm certainly not as in tune with that as others might be, and we could check on that and get you a potentially better answer, but I believe it's a year.
Okay, thank you very much.
Thank you, Kate. Next up is Steve Bonnell with Vesta Beat. Good afternoon, Steve.
Good afternoon. I'm going to try and word this first question in a way that everyone can understand. So these new CDC guidelines, low, medium, and high, given how that kind of changes the, for lack of a better word, mathematical view of when you jump up to each stage, have you all been able to kind of assess, okay, we've had these past surges to get to moderate, substantial, and high. Is it create a higher bar to go from low to medium, for instance, or is it pretty similar? Have you been able to look at that? And I know that's, again, a pretty mathematically tied question, but I'll start there.
Well, Steve, thank you for asking that. I mean, this is relatively new and looking at it, but I want to emphasize when there's federal guidance like this, it's put out there to, to be useful to every type of jurisdiction across the country. There's very rural, very urban. Ours happens to be a mix of a couple, a number of different types of settings. So again, this is guidance, and we work really closely. Our state is different than a lot of states. We work really closely with the Maryland Department of Health and determining what we're going to do. So it's not strictly a switch gets turned when you hit one or the other. But yes, this is less of a transmission based. We're counting every single case to determine whether we're going to move to this guidance or this guidance. It's emphasizing more the serious illness and the impacts those have on our healthcare support to patients and the ability to go forward with this. So with a very significant amount of, again, immunity conferred through infection, it's kind of adding that into the underlying math of that immunity background and placing the emphasis on severe illness. So it probably is a higher threshold to go from low to medium on the CDC scale, but that is, again, looking at where we are in this response.
I also want to say, Steve, before the CDC released their guidance on Thursday, we've been really looking at the California Smarter Plan. And one of the things that they do that we think is pretty smart, ironically, is that they talked about future variants. And they said that the metrics that you utilize for a future variant should change depending on the nature of that variant. What I mean by that is if you have an Omicron-like variant that's highly transmissible, but maybe not as pathogenic and doesn't cause as much severe disease, you may focus on hospitalization rates as a metric to key on. However, if you have a much more pathogenic virus and maybe it's less transmissible, you might count cases more closely because you know that each individual case is going to translate into more severe disease. And so in that case, the transmission numbers may actually be a better predictor of when you need to take actions than the hospitalizations, because at that point, it may be too late. And so I think there's some real wisdom in having some flexibility and nimbleness in our build out of our strategy to as different variants emerge, and we do not know what the next variant will look like, having some flexibility in our planning process and to plan for this, to be able to say, based on the characteristics of this particular variant that we're seeing emerge, here are the metrics that make the most sense in this circumstance. And so I think we're really, I think the CDC has done a good job of trying to bring those multiple variables together. But I think that depending on the nature of a particular variant, you may need to lean more heavily on some metrics than others.
So let me give you a practical example. Last fall, the mask mandate, when that was being debated and discussed, we looked at moderate and substantial transmission at the CDC. Is it safe to say, Dr. Stoddard, just basically what you kind of just explained, that using the current low, medium, high in terms of, if God forbid we have to put back masks on or things along those lines, making decisions like that, they're more likely not going to be tied to those low, medium, and high labels, and rather subsections within those labels, if that makes sense.
Yeah, I get where you're going, Stephen. And so what I would say is we would follow the CDC in most cases. But I think where we're suggesting, and we're not going to just randomly decide we're not going to follow CIC. What we're talking about is doing a planning process over the next several months as we go through and develop a strategy that reflects the CDC, but says in these limited circumstances, we may deviate because the realities on the ground say that we should. I would expect in those circumstances, the CDC guidance itself would change, but I think to be transparent to the public and talk about, if we saw X, we would respond with Y. I think that gives people a better understanding of what we're looking at and why we're looking at it. Because a lot of, I think a lot of the concerns that have been raised are around why we're doing things the way that we're doing in certain circumstances. I think we can do, because we've got some experience with different variants, we can start to explain the characteristics of variants that may influence any deviation from CDC that we would make.
And switching gears, I want to piggyback off Kate's questions here. When these two finalists have gone all the way to the end here, have kind of said they've had concerns about the political environment, has it been the local kind of political environment or more the national mood about these kind of debates about certain policies around COVID?
I think it's been a bit of both. Obviously, Dr. Gales faced hate speech directly. And so it certainly is, we're not immune to it locally. But I think part of the national tenor has influenced it, because there is also, much of the public health infrastructure is funded by federal dollars. And so you may see future politics involved in what's funded and how it's funded, or restrictions that are placed on public health at federal level. I think to a lot of it is, there is a federal component to it, but I also think that at least in the two cases that, the two individuals we're talking about, they had both they had some local concern too, given they can read the stories about Dr. Gales, and I don't know that they've spoken to Dr. Gales. I don't know that to be the case. They could have, and so they may have gotten, Dr. Gales was pretty overt about some of the things that he faced, and we, as the county executive alluded to, we didn't mask any of the things that he saw.
And I know a little bit about why Dr. Bridgers can, obviously, and again, as everyone's noted, that he's done a fine job, but can any of you just give me, if probably Sean or Dr. Stoddard can answer this best, but what kind of technical expertise kind of on the day-to-day level that this opening kind of will fulfill that Dr. Bridgers or any of you don't bring to the table? Because obviously you all are a lot smarter than me when it comes to this, and just kind of, I wanted, I guess, a technical answer in some respects about what this position brings to the table that you all don't.
I don't know. So I would say, obviously a lot of the infrastructure of public health relies on medical orders. And obviously we've had to use Dr. Carter from Prince George's County to sign off on many of our testing orders, the order for the prescription medication. So obviously we really need to eventually have an internal person to the county who can sign off, who's a medical doctor, who can sign off on those orders from a planning process, because obviously moving forward, that's just something you want to be able to have in-house and capability to address, because it's like you're less nimble if you have to rely on someone else outside the county inherently. Now, I would say the other big thing that we're probably looking for in a health officer is being, I don't actually believe that in terms of COVID-19, it's all that critical, because we're 2 years in, we have a lot of expertise within public health. And I think it's key, and we've always said this, that public health and medicine are two very distinct fields. And so having a health officer that isn't a medical doctor isn't necessarily going to make them a better public health practitioner. And we've had a team of individuals. Dr. Gales was a part of that team, Dr. Bridgers, myself, Dr. Kroll, Sean, and many more people that you don't see on a regular basis have been working together to develop policy and strategy and all those things. And so I do think it's important to have a health officer from a leadership perspective and from a help us coordinate those activities more effectively. But at the end of the day, there are a lot of public health expertise in Montgomery County that has been probably battle tested more than we prefer that they were over the last 2 years. But at this point, I think obviously we've got a system that is operating and has operated very effectively that we would expect a health officer to step into and augment and supplement. But really the need is really to address the long-term public health needs that the health officer is going to provide real strategic vision on how do we recover from this from a public health perspective. what are the things that we need to implement to improve health equity and access to care, and all these long-term problems that we know that we're going to have to make improvements on.
Thank you, everyone.
Thank you, Steve. I do not see any more questions from members of the media on the chat. Going once, going twice. Well, thank you everybody for joining us this afternoon. I guess we're done for today. Stay safe. Have a great afternoon. We'll see you next time.
Thank
Bye-bye.
you.
Thank you all.
Thank you.